Right, so good morning, everyone. I'd like to welcome all of you all physically present here and as well as who are joining through web to our CME lecture series conducted by KSA. So this has been going on right throughout, even through the COVID times. So today's lecture will be delivered by uh, one of the intensivists. That's a new consultant, not new consultant, but they are she is a breed of new consultants who are who are coming as consultant intensivist, which has been kind of was not there in Sri Lanka, but now we are kind of starting to produce these consultants. So our ICUs will be looked after by them. So this is one of the areas. Actually, we also find it as uh, uh, bit of a area that is lapse in the ICU care. So when you have intensivists, they are throughout there, they will be there. They know the patients in and out. So which will be a good thing for outcome of patients. So Buddhini Imbulpitiya is who is currently working as a consultant intensivist at National Hospital Kandy, looking after medical ICU and COVID ICUs. She did a initial training in MD. She has got through her MD and then she has opted for this subspecialty in intensive care. And following her training here, she has done a overseas training in Portsmouth, UK. Uh, and she has completed her training, and we are grateful that she's back in Sri Lanka rather than staying there because there's a huge demand for these intensivists. And she, out of hobby, she's in the European Council of Intensive Care Unit. She's involved in a lot of teaching and in the council, where she involves with training programs for visitation, especially her interest is visitation. So without much delay, I'll ask Buddhini to deliver the lecture on early morning scores. So actually, this is good for all the young doctors as well. So Buddhini, so
Thank you very much for that kind introduction. I'm grateful to the Kandy Society of Medicine President and Secretary and the Council members for inviting me to do this lecture today. I chose this topic, early warning score, not because I am much into resuscitation, but we rather than getting bad patients to the ICU and managing them at the very critical stage in the ICU, if we can detect these patients early in the ward setup, we can actually expect a better outcome rather than coming with multi-organ failure and going through multi-organ support inside the ICU. If we detect them early in general wards, including medical, surgical, and all other specialties, if we detect deteriorating patients early, we can have a better outcome. So my learning outcomes are about what is the early warning score. We will go through briefly about history, definition, and the importance, and about the components of these early warning scores. And then after the scores, what are we going to do? The escalation plan. And then briefly we'll discuss how to approach a deteriorating patient and about the different categories of patients that early warning score is indicated, and finally some recommendations. So when we briefly go through the history, towards the end of the 20th century, there were increased incidents in adverse events and unnecessary deaths in hospital patients. So these early warning scores were proposed as a potential solution for that. So the tools are clinical prediction models that generally use measured vital organs or vital signs to monitor patients' health during their in-hospital stay. So we monitor their vital signs and we make a clinical prediction model whether they will deteriorate or not. So these models identify the likelihood of patient deteriorating, and the deterioration can end up with death or admission to intensive care unit. So this triggers a care plan, an escalation plan when we identify the signs of deterioration. this was initially on paper base, and now mostly in the Western countries they have electronic health record systems. So by definition, early warning scores are widely used in hospitals to identify clinical deterioration in patients in order to initiate early intervention and management, such as increasing nursing attention, informing the provider, or activating a rapid response or medical emergency team. So these tools involve, they have numeric some physiological parameters including systolic blood pressure, heart rate, saturation, and they derive a composite score that is used to identify a patient at risk of deterioration. So actually the previous observational study, they suggest that when a patient deteriorates, it is shown up to about 24 hours. So if we monitor, so we can catch these patients. And the delay in treatment can result in ICU admission, death, or long hospital stay or cardiac arrest. So we can prevent these outcomes if we catch these patients during the period that they clinically deteriorate, which is about up to about 24 hours before the clinical event. So the purpose of early warning score is to ensure timely and appropriate management of deteriorating patient in general hospital wards, ensuring early detection, timeliness, and competency of the clinical response. So I will be going through mainly the National Early Warning Score, which is a tool developed by the Royal College of Physicians. And this early warning score in UK, it is mandated as a standard of care by NICE guidelines. This was initially implemented in 2012, and in December 2017, it was updated to a version of News 2. We will be going through the differences, and it is validated not only in the NHS system but also internationally, including emergency departments and in pre-hospital setting, that is by paramedics in ambulance service. So the components of the National Early Warning Score, it has 6 physiological parameters: respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness, or new onset confusion. So that was updated in 2017. And temperature. O is given as 0, 1, 2, or 3 to each parameter. So this is the initial chart that was implemented in 2012. I hope you can see that 0 is the normal value, and when you deviate from 0, you can see you are deviating more from the normal physiology. So respiratory rate less than 8 or more than 25 has the highest score. Again, saturation less than 91 has the highest score. And whether the patient is on oxygen or not. If the patient is on oxygen, they give a value of 2. Again, temperature less than 35 has the highest score. Systolic blood pressure less than 90 or more than 220 has the highest score. Again, heart rate less than 40 and more than 131 has the highest score. On level of consciousness, this is in 2012, alert. AVPU score is what is being used here. A is for alert. VPU is voice responsive, pain responsive, and unresponsive. All those three got marked as 3. So the total score was 20 here, and out of 20, the scoring system was done. Then in 2017, 4 important themes came up because they wanted to identify patients who are at risk of developing sepsis. So highlighting that new score of 5 or more was taken as a key threshold for urgent clinical alert and response for sepsis. Then again, they included another component in recording the use of oxygen. They included oxygen saturation in patients with hypercapnic respiratory failure, that is mainly COPD patients. And in the level of consciousness, they again identify the importance of including new onset confusion or disorientation, delirium, or any acute reduction in the Glasgow Coma scale. So it was included. So AVPU became ACVPU. So this is the current chart, latest chart. So I hope you can see that here this is aligned on ABCDE assessment. I will go through each. Now this is A plus B respiratory system. If we go by system examination, again in critical care and emergency setup, when we are approaching a deteriorating patient, we go through ABCDE assessment. So this is now aligned on that. Respiratory parameter, that is respiratory rate and oxygen, is taken as A plus B. Here, this is the respiratory rate. As I told before, more than 25 carries more than 3, less than 8 again carries more than 3 marks. Saturation scale 1, if the saturation is less than 91 carries 3 marks, if it is more than 96 it is 0. So then the new scale included is saturation scale 2. This is used for patients with COPD who are at risk of type 2 respiratory failure, hypercapnic respiratory failure. We target the saturation of 88 to 92 in these patients. And here I hope you can appreciate when the saturation more than 97 also, they have marked it as a high risk as a scale of 3. So normal saturation is given as 88 to 92. Then whether the patient is on oxygen or not, again a mark of 2 is given for that. So airway and breathing is up to that level. Then comes C, circulation. So under circulation, we have the systolic blood pressure and the pulse rate. So systolic blood pressure more than 220 carries a very high mark. 3, less than 50, up to less than 80 to 50 like, you get a mark as high as 3. Then pulse rate, again, it is similar to the previous chart. More than 131 is 3. Pulse rate of 111 to 132. Then 100 to 110, 1. Then from 50 to 100. 50 to 90, you have a mark of 0. Then when the pulse rate is less than 30, you have a mark of 3. Pulse rate more than less than 30, you have mark of 3. So this is circulation. Again, ABCD assessment, third is the circulation. Then we call disability in ABCD. D is for disability. Here we monitor the conscious level. So newly included one is new onset confusion. So alert is 0. If you have new onset confusion, delirium, disorientation, agitation, any of these come here. And voice responsive, pain responsive or unresponsive, all these carry a mark of 3, the highest. Then lastly, in ABCD assessment, we have exposure. That is in the new score, we monitor the temperature. So if the temperature is more than 39, you have carried the highest mark 2, or less than 35, highest mark of 3. So in total, again here also you get a total score of 20, because saturation you take either scale 1 or 2. So I hope these are the two, the newest early warning scale, national early warning scale, currently implemented in UK. So depending on the total mark, we can risk categorize these patients at low, medium or high risk. So the clinical risk is low when the aggregate is 1 to 4. When it is 5 to 6, risk is medium. When it is more than 7, it is high risk. So low risk patient, when the aggregate score is 1 to 4, prompt assessment by the ward nurse to decide on change to frequency of monitoring or escalation of clinical care should be carried out. When the risk is low to medium, that is or when there is a score of 3 in single parameter, the nurse has to call the medical ward-based doctor to assess the patient. So urgent review by a ward-based doctor should take place. So the urgent reviews usual recommendation is within 30 minutes. And also they should decide on change of frequency of monitoring. Then medium risk is when the score is 5 to 6. Again, urgent review by ward-based doctor or acute medical team. This could be a nursing team, may not be in our country, but other countries they have acute nursing teams or critical care team. Escalation to critical care team should take place. When it is high risk, emergency assessment by critical care teams, sometimes they have outreach critical care doctors and nurses who go and assess these patients in wards. So when the score is more than 7, they should call critical care team and escalate this patient. Patient might be need to transfer to high dependency unit. And the response team, the team, critical care team or med team, they should be skillful on critical care skills and airway management. So depending on the scope, we categorize the risk and the response should be initiated. So the escalation protocol, so when the score is greater than 0, warrants increased surveillance of these patients, and this may warrant increased frequency of observation, considering notifying the team leader, which could be a nurse or a doctor. In UK system, they have nursing staff that they escalate into. Then the total early warning score reaches an initial trigger point of 4. Then you have to escalate the protocols. Patient should be escalated into relevant protocols. And we have to decide on the increasing frequency of observation or notification to the relevant medical officer, which could be the medical registrar on call, or it could be the ICU registrar on call. And depending on the scoring system, you have to take the patient to HDU or ICU. Again, this is about observations. Frequency of observation can happen half an hourly if the score is 4 or above. But if it is less than that, hourly observation can take place depending on the patient's stability. Now, this is an example of a decision tree that is taking place in New Zealand with modified early warning score. So if the score is more than 4, this is the modified early warning score, they have made some changes. If the medical officer or registrar is not reached, then they directly contact the consultant. When the score is more than 8, also they directly may contact the medical emergency team. So we need to have this type of escalation plan if we are going to implement early warning scores. Then, as we spoke about this early warning score, it is important to know how we should approach a deteriorating patient. So, as I mentioned before, the ABCD approach is implemented to identify the critical illness or deteriorating patient. So, we have to be aware of how to do this. ABCDE stands for airway, breathing, circulation, disability, and environment. Here again is the chart that is used in by the NICE guidelines and NHS system. So if you go through the several categories, so when a patient is deteriorating, we have to maintain patient's airway first because it is a priority. So if the patient can speak to us, we know that patient's airway is patent. And if you can hear any noises or secretions, it's important to suck out those secretions and maintain the airway with airway maneuvers. We can do the simple maneuvers as head tilt, chin lift, jaw thrust if there aren't any cervical spinal injuries. And at the end of clearing secretions, removing foreign bodies, opening up airways, at the end of A, we recommend putting on oxygen. When we are talking about a deteriorating patient, the recommendation is to put on the highest flow rate of oxygen available. Then comes B is for breathing. So breathing usually is for the respiratory system. So we have to inspect, palpate, percuss and auscultate and identify whether patient has any life-threatening respiratory issues. So patient could have emphysema, patient could have pneumothorax. So if you identify any of these, we have to correct it then and there before you go to the next step. So after examination of B, we put the patient's saturation probe and monitor the saturation. And make sure our goal is sufficient oxygenation and ventilation at the end of B. So that depends on patient. Might have to intubate the patient if the patient is having a severe respiratory compromise. Then comes C. So in C is for circulation. We do the cardiovascular system examination briefly, from periphery to central. So examining, palpating the peripheries, whether they are cold, what is the capillary refilling time, then the pulse rate, volume, blood pressure, and then auscultating the heart and the lung bases. So all these things include in C. And at the end of C, we take intravenous access. We start the patient on IV drip. If the patient is having a lower blood pressure and clinical indicated, we can start a normal saline drip or fluid bolus. So depending on patient's circulatory compromise, you might have to initiate massive hemorrhagic protocol if it is a trauma patient. So depends on the patient, and we have to stabilize the patient. So at the end of C, we send blood for investigation. We do ECG, chest X-ray, and those relevant investigations. Then D is for disability. Again, D is standing for neurological examination. So AVPU is what commonly used in medical wards. A for alert, B voice responsive, P pain responsive, U unresponsive. Dusker-Coma scale is the validated tool in trauma. So you can use Dusker-Coma scale as well. So the newest news to include ACVPU, having new onset confusion at the end of A. So we do a brief examination, talk to the patient again, assess the consciousness, and examine the pupils, see whether reactive or equal, and focal neurological signs can be looked for. And at the end of this short neurological examination, we check the blood sugar. So that is how the D examination ends. Then lastly, we do the E is for examination again. Here you have to do a top to bottom examination, expose, seeing the patient, look for any edema, rashes, any injuries, any bleeding points. There may be a focus of sepsis. So that has to be looked for after, with ensuring patient's privacy. And you can take a focused medical history, ample history as well here. At the end of E, we check the temperature. So this is the ABCD assessment that is recommended, and at each point you have to do several things. At the end of A, we do put the patient on oxygen. B, we check saturation. C, we do the cannulation, take blood, give fluid, investigations. And D, we check the blood sugar. E, we do the temperature check. So this is ABCD assessment to identify a deteriorating patient. This is the same thing that has been now implemented into the scoring system that I described before. So there are other different categories that are important categories when we look after critical ill patients, like maternal, pediatric, and newborn patients. So there are different early warning scores for these patients as well. MUSE is maternity patients, PUSE pediatric, NEWS newborn early warning score. So these are from the New Zealand guidelines. So there are early warning scores implemented. It is the same as before. Only I think it is the same parameters actually in this New Zealand pregnant women early warning score. And for pediatric, they have included capillary refill time other than the previous scores, and respiratory distress score. In neonates, other than it's actually different to the normal scoring system. They have work of breathing, color of the patient, and behavior and feeding as well incorporated. So that is in short that you have to defer the early warning score depending on the category of the patient. So my recommendations are that if we are going to implement early warning scores, we have to educate our staff, we have to implement training systems to doctors and nurses on how to do the early warning scoring system. It can be paper-based, or we can also get the IT people to do a software and do an electronic record system. And they have to be educated on escalation pathway. So we have to develop protocols and escalation pathway, and this should be incorporated into our national guideline if we are going to implement this as a national level. So there are different sets of wards. In medical wards, we have medical registrars to look into, but other wards don't have a person to be escalated. So hospitals or nationally, we should develop medical emergency team or rapid response team to escalate these patients. Or a critical care outreach system has to be implemented if we want to have this successful. Otherwise, the scoring system itself will not give rise to an endpoint. Then once everything is developed, we have to implement it in general for setup, medical and surgical. So these are my references. Thank you and stay safe. If you have any questions, I'm happy to answer.
Any questions? If you want to ask questions, guys. Not Buddhini. You on the mic?
So we can use that as well. Now,
We can download it on the phone and then
can be it's like a language when everyone is using the same scoring system. Then the paramedical staff use the early warning score and say this is the value 7 or 8 depending on the patient's physiological parameters, and then they hand over to the EDU doctors. Then they can do their calculation and if the patient is deteriorating or not, that can be identified. And when we have the septic patient, when we give fluids and antibiotics, and when we start the management, the score might come down. So it's like a common language that we can identify about patient improvement and deterioration.
take class performance.
Yes, once you are used to it, I think it is a easy system.
Any other questions? Let's see. So, in the absence of any questions, I'd like to call upon Dr. Ajit Kuratna to give away the certificate to Dr. Buddhini. Sir, Keith, sir, Keith, give us. Sorry. So that concludes our lecture, but another reminder, our sessions will be falling on 24th, 25th, 26th of March. So we like you all to participate. I think a lot of abstracts have come. Actually, we have got about 130, 140, nearly 140 abstracts. So which is a good, which is good. So we will be trying to accommodate almost all with after corrections and all that. So we want your full participation for that. And there's another kind of a social event we are trying to organize a sing along with Anasi Malavana on 4th. That is a public holiday, 4th of February at Earth's region. This will be a kind of a sing along thing where the dinner will be served and the dinner and then sing along with some you know with I suppose some fellowship also. So we ask everybody to participate as much as possible. Tickets are available in Kandy KSM office, and we'll be sending tickets to all the nearby hospitals also. So please try to come. And I hope the COVID situation will be very quiet during this period. Since everything went down, we thought we'll have a social gathering because for last year we couldn't have any social events from the KSM. So we thought we'll have a small event. So try to participate as much. Thank you very much.